Günaydın. Kongrenin bu ilk gününün ilk oturumunda tabii ki çok değerli konular ve konuşmacılarımız var. İlk konuşmasını yapmak üzere ECMO'da oksijenatör membrandaki değişimlerin değerlendirilmesi konulu konuşması için Lean Verdansk konuşmayı. Good morning. Yeah.
Good morning, everybody. I'm Leen Verkamst. I'm an ECMO coordinator / perfusionist from the University Hospital in Belgium. I'm very active in education and training. I'm very active in ELSO. And I'm very, very happy to be here. So thank you for the kind invitation. Can everybody understand me well? I understood there is simultaneous translation?
Yeah, there's simultaneous translation.
Okay. Yeah, okay, so I was asked to come and give a few ECMO talks, ECMO-related talks. So the first topic I want to share is how we exchange, or when we exchange our membrane lung during the ECMO run. There are going to be a few questions I will answer, or at least I will try to answer. And the first question is, what is membrane lung failure? What's the definition? And what is membrane lung dysfunction? And secondly, and most importantly, when do we intervene and how do we intervene? If you look at the ELSO data registry, I don't know if you put in data in the registry, but there the only thing you can find is when you have to change your membrane. It's not defined as membrane lung failure, but it's defined as need to change out. So whenever you need to change out your membrane, you have to register in the registry. And based on this, the registry gives you the complication of membrane lung failure. But it's actually a need to exchange. And there's a huge variation reported. It goes from 10, 15% up to 35, 40%. In some centers even more, a huge variation. If you look at the reasons for need to change out, you see this list. There are 8 reasons defined by the ELSO registry why you would have a need to change out your membrane. Such as decreased gas transfer, acute obstruction, coagulopathy, and it's mostly about clots. So this is already important information. How should we define membrane lung failure and dysfunction? If the performance of your oxygenator is just not longer in line with your information for users, like with respect to gas transfer, resistance to flow, leakage, we should call it membrane lung failure. But if the membrane lung is still functionable, but is becoming a burden to the patient, because of inadequate support, consumptive coagulopathy, hemolysis, platelet consumption, we should call it membrane lung dysfunction. So when do we interfere? With a failing membrane or when a membrane is not functioning properly anymore? So if, as we said, that clots are the main reason for membrane lung dysfunction, we should look for indicators. And we know from several studies, and this is one of it, we know from several studies that clot formation starts the moment you go on ECMO. Clots grow on all membrane lungs. And small clots, you can see from this data, they don't give any significant decline in oxygen transfer. They don't give any significant increase of resistance. So we cannot detect them with our usual parameters. But maybe they're not clinically relevant. This is another paper that says you could have thrombi in 80% of the ECMO circuits. And depending on where you find your thrombi, they will give different clinical signs. The inflow thrombi are very pressure sensitive, which is logical. But the deep thrombi, and that's the majority of the thrombi are there, they have no effect on gas transfer, on resistance. And then you have the thrombi that are trapped in your pump, and they give hemolysis. What's also important is that it's not only about thrombi, but if you do an autopsy in the non-survivors, you see that actually a lot of them, and this study, 60% of them had thromboembolic events. And another thing that's interesting, and I come back to this later, if you change your anti-co protocol, or at least the monitoring of your heparin to anti-10A guided, you will have a 75% reduction of membrane-lung exchanges or thrombi formation. And coming back to the thromboembolic events, it's not only this study, there are several studies, and this is a study that is referred to very often because in this study, it's a huge study of autopsy in patients who had ECMO. It's a study from Leipzig, and they found clots in 50% of the patients. And in 80% of these patients where they found clots, they did not see any clinical signs of membrane lung or circuit clot formation. So we have inevitable clot formation via the two pathways, the clotting pathways. You've all learned them in your training, the contact pathway and the tissue factor pathway. The clots cause platelet and clotting factor consumption, leading to thromboembolic events, but also, and maybe more importantly, to bleeding. And bleeding is associated with a higher mortality than clotting events. So, but it's all related. If you have a clotted circuit, you'll have a bleeding patient. So maybe we have to look for these clots earlier than we can see them. And how can we find the early clots? According to this paper, they said that the most sensitive parameter is exhaust CO2 measurement. But I'm aware not a lot of people are doing this. But what's very popular, and there's increasing evidence every week, papers coming up, is the increase or the delta in D-dimers in this patient. You have a baseline, and if you have a delta increase of more than 25 or 30 milligram per liter in 2 days, you can really say there is something going on inside my circuit is clotting. And this is before any other parameter will show. So you have many parameters, I'm sure you all know them, more resistance, leakage, visual clots, gas transfer. And some are more sensitive than the others, and depending on the place of the clots, we will have earlier signs from some parameters than from others. But when do we take action, or when should we take action? We should take action, first of all, of course, when the membrane lung no longer provides intended support, but second of all, when it becomes a burden to your patient, like in terms of consumptive coagulopathy. So we need guidelines, and that's the most important goal of my topic, to tell you that every center should have a standardized way to look at, to monitor, and to exchange your membrane, taking into account that you should not harm your patient, you should avoid urgent change-out and insufficient support. The guidelines should take into account the contamination risk, the support dependency of your patient, of course, the available resources, the team competency and roles, and the prospect of weaning. If your patient is about to be weaned off, of course, you should not exchange your membrane. Just take in mind that in the US, and that was according to this paper, 1 patient per month dies as a result of an emergency oxygenator change-out. So we really have to avoid this. So now we have to establish our threshold, and that's what we did in the COVID period. This is a paper we made, I made together with some experts from the ELSO, and it's a very nice paper to implement in your center. It's a basic, and you just have a look at it and see what you can use in your center. It's about a very nice algorithm of how to approach membrane lung dysfunction. But you have to adapt it to your local protocol because everybody has different roles, different lab monitoring availabilities. That's our protocol, what we use in our center. And you see again the very nice algorithm and the 4 pillars of what we look at. We look at consumptive coagulopathy, we look at hemolysis, we look at internal resistance, and we look at gas transfer. And we defined who is monitoring what. We define when we have to act and when the nurse have to notify or the physician have to notify the perfusionist. And then we define which action has to be taken. And this way we have a very standardized way. Just to go over very quickly over the 4 pillars. So it's internal resistance. We have this trend we follow, and as soon we define very well if it goes up like this or if it goes exponentially, that's the action the nurse has to take, and that's the action the perfusionist has to take. The same with gas transfer. We define very well what gases they have to check, what's supposed to be the number. For example, if your post-oxygenator gas drops below a certain level, you have to recheck. If it drops further, you have to call the perfusionist. And then also the action of the perfusionist is defined. The same for hemolysis. We define how to check for hemolysis, when to take an action. And the same for consumptive coagulopathy, which has become the most important monitoring for us with respect to membrane lung dysfunction. And then I'm talking about D-dimers and fibrinogen. Okay, if you look at the D-dimers, that's a few of our patients. It really is the case. If we see an increase, a delta of, we say a delta of 20, then we change out, and you see immediately a drop, and it becomes back to the baseline level as before your exchange. So what's the difference between our protocol before and after? So before, we just have a standard membrane lung monitoring with a late action and APTT control. Since the membrane lung protocol, we also control and look at our markers of coagulopathy, like D-dimers and fibrinogen. We take early action, and we do dual monitoring, APTT and anti-TNA. What we see, and it's maybe very difficult it's going to be published, but this is what I can already show, is that we had much more exchanges before our protocol than after our protocol. And most of our exchanges we had before our protocol, it was because of bleeding, because of consumptive coagulopathy, which we don't see now anymore. So we have also a decreased exchange despite more sensitive membrane lung screening and the change of our threshold. So this is contradictory. But probably it's mainly because of our change, our dual anti-co-monitoring, because this was stated in paper. If you monitor APTT with anti-TNA, you have a reduction in circuit clotting and circuit exchanges. And we also saw a decrease in bleeding. So the combination of our membrane lung exchange protocol and our dual anti-co seem to be very, very effective. And I can only recommend this to implement. This is our anti-co. I can share it with you. I don't have a lot of time. I have to talk about this for 15 minutes. I could go on for a few hours. But so we now do APTT and anti-10A guided heparin monitoring, anti-10A to guide the heparin dosage, and APTT additionally to assess the bleeding risk and treat factor deficiencies. So I'm not going into detail, but please, if you're interested, you can ask our protocol. It's very straightforward. If your anti-10A is out of your desired range, what should you do? If your APTT is out of your desired range, what should you do? What are the others doing? And that's why I thought I'm going to tell this, because we did a survey in Europe, and in Europe the majority is giving heparin, that's we know, but the majority is monitoring the heparin with either APTT or ACT. Not so many people are doing the dual monitoring, but it really adds a lot to our circuit integrity. So we, in the context of a membrane lung monitoring, don't just only monitor, like in the ELSA registry, your need for change out, but also the related adverse events, like bleeding, hemolysis. It's related to circuit clotting. Patient thrombus, I know it's harder, maybe it's most often via autopsy, but if you have any indication that there are thromboembolic events in the patient, please report. Also report the missed membrane lung failures, because what you see in the literature is the need to change out, but we miss a lot because people are weaned, because we just tolerate, we don't support the patients properly anymore. Consider dual anti-co monitoring. It's really worthwhile saving you more circuits, and never, never, never stop heparin. So the first answers, membrane lung dysfunction, I'm just continuing because I am running out of time. So in conclusion, membrane lung dysfunction, we should be defined as membrane lung which firstly doesn't provide the intended support, but secondly becomes a burden to the patient, very importantly. There are several variables to identify worsening membranes, and the sensitivity may change, but we thought the most sensitive parameters were the D-dimers. You should all have central guidelines to standardize membrane lung monitoring and intervention, because that's the only way you can improve. And your early intervention will minimize complications of clot and bleeding, and that's more importantly in your patient. So that's it. I rushed through it. If there are any questions, please, you can ask them now. I don't know if you can ask them now or later. The questions.
Thank you for your nice speech, Lynn. Is there any contribution or any questions? Yani salondan soru ve katkı Lynn'e varsa eğer.
I'm here the whole day.
Okay.
Thank you.
Thank you, Lynn.
Pediatrik kalp damar cerrahisinde miyokardiyal korumayı Normus Nureka sunumunu yapmak için sahneye alıyoruz.
Okay. Good morning, dear ladies and gentlemen, dear Chairman. And my name is Dr. Norman Sikora. I've been into pediatric cardiac surgery and perfusion for more than 20 years. And also I'm teaching students as assistant professor, not only perfusionists, but also medical doctors. And last but not least, I'm also the newly elected General Secretary of EBCP. So I was asked to come here, and I'm very happy to be here to talk about some very important subjects in pediatric cardiac surgery. So one of very important subjects is, of course, myocardial protection. And some pictures before I start. I come from a very small country, Latvia, which is located in north and eastern part of Europe, with the very beautiful capital city we have, Riga. And this is my hospital and also my university. Okay, so ensuring myocardial protection is one of the most important goals we have in pediatric cardiac surgery, not only in cardiac surgery at all. And it is very important for every cardiac team to know different myocardial protection methods and to be able to use them whenever it is needed. Because every cardiac surgical procedure, to ensure that it is successful, we must protect myocardium as much as we can. And normally, the myocardium has very large functional reserves and actually is capable to compensate also very significant damage. But it is directly dependent on each patient, of course, functional characteristics and also disease. And in children and newborns, despite we have many researches available, we still don't have unified and specific common strategy how to protect myocardium. Because also we have a lot of differences between myocardium of child and adult, and also a child would have great variability of congenital heart defects. And if we talk about newborn and adult hearts, we have a lot of different metabolic, functional, and biochemical differences. For example, myocardium of newborn uses glucose as a primary energetic source. That means that neonatal myocardium would be much more resistant to hypoxia if we compare to adult. But on the other hand, myocardium of neonates, it's much more prone to excess water, and that means that the edema would be much faster in neonatal myocardium than in adult. And this is a very big issue for those who is using crystalloid cardioplegia for newborns. However, if we talk about children, the same basic principles we use also for children as for adults, so arresting the heart and diastole, ventricular decompression, and also hypothermia to reduce metabolic demands. And for children, we have three most commonly used myocardial protection strategies. We have blood cardioplegia, we have custodial, and we have del nido cardioplegia. And the question is, which one is the best one? So if we have a look at the historically older blood cardioplegia, it is still used a lot nowadays because in this blood cardioplegia we use blood for myocardial protection. Therefore, we actually reduce incidence of arrhythmias and improve cardiac function in early postoperative period because we actually preserve high energy phosphates. Second, we can use the historically designed cardioplegic solution by Brett Schneider long time ago. But nowadays it is significantly improved, and we know this solution as custodial solution. Custodial solution is a bit different from others. It is intercellular crystalloid solution, and concentration of different electrolytes is similar to that inside the cell. And unlike other cardioplegic solutions, custodial has decreased sodium and calcium concentration, and this actually causes hyperpolarization of myocyte membrane. A big advantage of custodial is that you can administer it only once, and the action is prolonged up to 3 hours, and therefore it is mainly used for very long and complex cardiac surgeries. And the third, del nido, initially it was developed for pediatric cardiac surgery, but recently they started to use more and more often also in adults. This is depolarizing agent. Cardiomyocyte is maintained in constant depolarized state, preventing it from contracting, and the heart stops. We can say in a way it is similar to a well-known St. Thomas solution. It is also mixed together with blood 4:1 ratio. But if we compare to St. Thomas, then it has big advantage. It is needed only single administration, and the action is prolonged up to 90 minutes. So, which of course may shorten aortic occlusion and CBB time because we don't need repeated administration. It may reduce hemodilution because actually it's over blood cardioplegia, and it lowers requirement of inotropic drug support in early postoperative period. And we also don't see so many times fibrillation after aortic occlusion. So it's a very good question now, which strategies, which of them is the best for child? And what can be seen in literature, it's actually not a lot, but the first research I want to show you, which actually comes from Turkey, And this research actually compares all three strategies for children with TGA going through switch operation. And they actually conclude that custodial and del nido has shortened cross-clamp time and bypass time and reduced inotropic need and shorter ventilation. And mortality is the same in all groups. Another research can be found is when it is compared del nido and conventional cardioplegia in infants and neonates. So actually they concluded that if you use old blood cardioplegia, old del nido, it's not very big difference, but of course we have to think that del nido we can administer just once. That means that we can shorten CPB and occlusion time. Here in this research, they were comparing custodial versus old blood cardioplegia. And also, they observed that inotropic score were not significantly different between all groups, and also cardiac troponin levels and ventricular fibrillation did not differ between groups. But again, we have to keep in mind that custodial we can give just once and use for very complex surgeries. We don't have to administer again. And last, there is another research comparing actually del nido and custodial in between, and they concluded that there is not much difference. They work very well in all cases. So to conclude, if we talk about del nido and custodial and blood cardioplegia, actually nowadays it is known that del nido and custodial are superior to blood cardioplegia, especially in neonates. Del nido and custodial, which one is better? Actually, generally equivalent and very effective for children and offer similar protection, both of them. But custodial, it's good for longer ischemic times. It has lower viscosity and single dose potential. And last but not least, historically old blood cardioplegia, you can still use it with good results, but inferior for neonates in metabolic stress markers. Okay, thank you for attention.
Thank you. Soru ve katkısı olan var mı acaba salonumuzdan? Teşekkürler. Thank you.
Thank you.
Şimdi next konuşmacımız Lucia Ajro. Yok mu?
Cüneyt Bey'e bağlandı. Lucrezia var mı?
Kim olduğunu tanıyor musun?
Cüneyt Narin'i alabilir miyiz? Cüneyt Narin'i. Tamam. Cüneyt Hoca'nın şeyini Fehmi. Hocam hazır değil de şu an bir sonraki hocamınkini verelim. Lucrezia yok. Onun yerine olmadı.
Özlem beni duyuyor musun? Özlem?
Şimdi Türkiye'de kardiyak cerrahi tarihine farklı bir bakış. Yok değil mi? Pardon.
Kardiyak cerrah gözüyle.
Pardon, yanlışlık oldu, kusura bakmayın. Kardiyak cerrah gözüyle minimal invazif kardiyopulmoner bypass konusunda Cüneyt Bey davet ediyoruz. Cüneyt Bey'i davet ediyoruz. Online katılacak.
Günaydın, merhaba. İyi bir hafta sonu, iyi bir kongre diliyorum. Sesimi net duyabiliyor musunuz acaba?
Duyuluyor Cüneyt, gayet güzel.
Tamam, merhaba Levent'ciğim. İyi toplantılar diliyorum hepinize. Aranızda olamadığım için çok üzgünüm. Ne yazık ki mesleki gerekliliklerden dolayı şehirden ayrılmam mümkün olmadı. Ama kalbim hepinizle beraber. Öncelikle beni toplantıya davet eden organizasyon komitesine ve kongre düzenleme kuruluna çok teşekkür ediyorum bu fırsatı bana tanıdıkları için. Kardiyak cerrah gözüyle minimal invazif kalp cerrahisi, küçük kesik kalp cerrahisi ile ilgili birkaç deneyimimi sizinle paylaşmak üzere yanınızdayım. Çıkar çatışmam olmadığını belirtmek isterim. Kalp cerrahisinin babası, father of the heart surgery diye nitelendirilen Lilihai, 1950'li yıllarda ebeveyninin sirkülasyonunu çocuğa bağlayarak VSD defektini kapatmasıyla açık kalp cerrahisi konseptini başlatan cerrah olarak tarihe yazılmıştır. Tabii o zamanlardaki operasyon teknikleri çok büyük salonda, salonun neredeyse 1/3'ini dolduran bir kalp akciğer makinesiyle yapılan aşamalardan şimdi çok daha farklı konumlara gelmiş gözükmektedir. Tabii 1953 yılında Gibbon'ın kalp akciğer makinesini keşfetmesiyle kalp cerrahisinin gidişi ve seyri çok daha farklı bir boyuta ulaşmıştır. Minimal invazif kalp cerrahisini neden tercih ediyoruz? Normalde çok uzun zamandır yapılan stenotomi ile yapılan kalp cerrahilerinin neden küçük kesiye evrildiğinin sebeplerini arka planda bakmak gerekiyor. Tabii 1990'lı yıllardan sonra popülarite kazanan küçük kesik kalp cerrahisinin en büyük tercih edilme sebeplerinden bir tanesinin daha az travma, daha az transfüzyon, daha az operasyon sonrası ağrı, daha hızlı rehabilitasyon, kozmetik kazanımlar ve postop iyileşme süresindeki avantajlar olarak belirleyebiliriz. Tabii bunlar hastaya sağlanan ana kazançlar. Cerrahiye sağlanan ana kazançlardan bir tanesi de hastanın eğer reoperasyon gerekliliği söz konusu olursa cerrahi insizyonun çok daha kolay ve komplikasyonsuz yapılabileceği akılda tutulabilir. Minimal invazif kalp cerrahisinde 4 tip seviye var. İşte direkt görüntüden, robotik kalp cerrahisinden 1 santimlik portlarla yapılan operasyonlara kadar 4 seviyede kalp cerrahisinde kullandığımız insizyonları sınıflandırabiliriz. Tabii kesi oranı küçüldükçe teknolojinin katkısı da o oranda artmakta. Küçük kalp cerrahisinde ne tür insizyonlar yapıyoruz? Küçük kalp cerrahisi, minimal invazif kalp cerrahisinde yaptığımız insizyonlar küçük stenotomi yani hemistenotomiler, mini stenotomiler ki genelde aort kapak ve ascending aort cerrahilerini bu kesiyle yapmak mümkün. Aynı zamanda sağ torakotomi ile yaptığımız operasyonlar ağırlıklı olarak mitral ve aort kapağını kapsamakta. Burada aort kapağı yönelik sağ anterior torakotomi, mitral kapağı daha ağırlıklı olarak sağ anterolateral torakotomi, sağ aksiller torakotomi yoluyla hem aort hem mitral kapağa ulaşmak mümkün sağ torakotomide. Peki sol torakotomide ne yapıyoruz? Yani toraksın solundan yaptığımız toraks kesilerinde genelde minimal invazif bypass cerrahisini yapıyoruz. Bazı özellikle hastalarda da sol ventrikül anevrizma cerrahisi ve aritmi cerrahilerinde uygulamak mümkün olmakta. Tabii standart yaptığımız stenotomili açık kalp cerrahilerine göre küçük kesiyle yaptığımız kalp cerrahilerinde ne tür farklılıklar var? Tabii burada en önemli farklılıklardan bir tanesi preoperatif hazırlık. İkincisi anestezinin bize sağladığı olanaklar. Üçüncüsü siz perfüzyonist arkadaşlarımızın bize sağladığı olanaklar. Cerrahi alet ve sarf malzemeleri bu küçük kesi operasyonlarında çok kıymetli. Aynı zamanda cerrahi ekibin deneyimi de büyük önem arz etmekte. Tabii preoperatif hazırlığın ana unsuru aslında radyoloji. Radyolojide en önemli baktığımız şey akciğer kapasitesi, akciğerle ilgili problemler, periferik kanülasyon için güvenli yerlerin tespiti. Aortada ateroskleroz ya da anevrizma varlığı küçük kesi operasyonlarda periferik kanülasyonu ciddi şekilde engelleyen, komplikasyon riskini arttıran bir nokta. Birçok araştırmada bakılmış ki periferik kanülasyon küçük kesik kalp cerrahisi operasyonların başarısında en önemli etkenlerden birisi. Bu bakımdan periferik damar hastalığını görüntüleme, karotisle ilgili bir problem varsa onun tespiti çok kıymetli. Aynı zamanda kardiyoloji ile yapılacak olan eko tetkikinde intrakardiyak bir patolojinin varlığının olup olmaması da kıymetli. Preoperatif değerlendirmeler neticesinde bizim minimal invazif kalp cerrahisi operasyonları yapmamızı engel olabilecek en önemli noktalardan bir tanesi daha önce hastanın toraks operasyonu geçirmiş olması. Bu tip operasyonların adezyon ve yapışıklıklar nedeniyle kalbe ulaşmayı pek mümkün kılamayacağı, bu nedenle küçük kesiyle operasyonların yapılamayacağı akılda tutulabilir. Ama bazı farklı ayrıntıların da olup daha önce torakstan operasyon geçirmiş hastaların opera edilebildiğini söyleyebiliriz. Ciddi periferik arter hastalığı da bu tip operasyonlarda önemli bir kısıtlayıcı etken. Keza asenden ve desenden aort patolojileri işte diseksiyon ya da anevrizma gibi, aort kapaktaki yetmezlik, orta ya da ileri seviyedeki yetmezlik kardiyoplejinin etkin bir şekilde verilmesini engelleyebilir. Belirgin göğüs deformiteleri işte pectus excavatum dediğimiz kunduracı göğsü gibi problemler kalbin birçok anatomik yapılarının görünmesini engelleyebilir. Bir de mitral kapak operasyonu planladığımız hastalarda ciddi mitral anüler kalsifikasyonlar bu tip operasyonlarda engelleyici etken olabilir. Bu görüntü bize sağ torakotomi ile mitral kapak operasyonu planlayan bir cerrahın görüşünü gösteriyor. Yani gördüğünüz üzere alanın yarıdan fazlasını, kalple ilgili alanın yarıdan fazlasını sağ atrium, bir kısmını sağ ventrikül ve sol atrium, bir kısmında aorta. Burada sol ventrikülü göremiyorsunuz. Cerrah buradan hiçbir şekilde sol ventrikülü görmüyor. Sağ ventrikül ve sol atriumda çok kısıtlı bir oranda görüyor. Aortayı da keza öyle. Bu bakımdan bu görüş açısından operasyon planlayan bir cerrahın mutlaka kalbi ayrıntılı bir şekilde radyolojik olarak preop görüntülemesi çok büyük önem arz ediyor. Keza preoperatif tetkikler sırasında periferik kanülasyona engel olabilecek sol tarafta gördüğünüz, soldaki resimde gördüğünüz üzere ilyak arterdeki bir tortuozite ya da bir vasküler malformasyon, perfüzyonu olumsuz etkileyecek bir malformasyon ameliyat sırasında büyük komplikasyonlara yol açabilmekte. Yine preoperatif değerlendirmede bilgisayarlı tomografi ile değerlendirdiğimiz aort diseksiyonu, ilyak arter tıkanıklığı, femoral arter tıkanıklığı, işte sol altta gördüğünüz aort kalsifikasyonları, yine sol altta, ortada altta ilyak karotit arter aterosklerozları ciddi problemlere yol açan komplikasyonların nedeni olarak görülebilmekte. Anestezi çok önemli. Anestezinin bize katkısı çift lümenli entübasyon, bazen tek normal entübasyon bronşal blocker desteği, transözofajiyel eko, anestezistin bu konuda yetkin olması biz cerrahların elini çok güçlendiren bir nokta. Aynı zamanda periferik perfüzyonun beyinde yarattığı olumsuz bir etkinin varlığını tespit etmede NIRS monitorizasyon, jugüler venöz kanülasyon anestezinin yapması cerrahi açıdan büyük kazanımlar sağlamakta. Bir de tabii ki ameliyat sonunda defibrilasyon olanağı sağlaması açısından defibrilasyon petlerinin öncesinde anestezi sırasında yerleştirilmesi de büyük kazanımlar sağlamakta. Sol üstte gördüğünüz üzere jugüler venöz kanülasyonu yerleştirilmiş, anestezi tarafından yerleştirilmiş bir hasta. Keza sağ üstteki fotoğrafta da hem transözofajiyel eko probunu görmekteyiz, oral yoldan yerleştirilen. Aynı zamanda entübasyon tüpünün içerisinden gönderilen sarı kateterin bronşal blocker aracılığıyla tek akciğer solunmasına katkı sağladığını gösterebiliriz. Aynı zamanda transozofajal eko ile periferik kanülasyonda sol altta gördüğümüz üzere superior vena cava'daki kılavuz tellerinin varlığının gösterilmesi de cerrahı önemli yönlendirici etki yaratmakta. Tabii perfüzyon en önemli noktalardan bir tanesi küçük kesik kalp cerrahisinde. Vakum olmazsa olmaz. Vakum mutlaka venöz drenajı sağlamada küçük kesik kalp cerrahisinde önemli bir unsur. Hedef odaklı perfüzyon son 10 yıl içerisinde önemi çok ciddi bir şekilde vurgulanmış bir nokta ve hedef odaklı perfüzyon periferik kanülasyon yapılan hastalar için çok kıymetli parametreler vermekte. Çünkü hedef odaklı perfüzyon bazen yüksek perfüzyon basınçlarında bizim indeksi düşmemize olanak tanıyan DO2 değerlerini vererek bizim daha güvenli bir operasyon yapabilmemizi ve fazladan komplikasyon çıkartacak işlemlerden bizi alıkoymada büyük katkı sağlar düşüncesinde olabiliriz. Sürekli kan gazı ve hemoglobin monitorizasyonu da küçük kesik kalp cerrahilerinde önemli avantajlara sahip. Tabii uzun etkili kardiyoplejiler bir önceki konuşmacının da söylediği üzere kustodiol ve delnido gibi solüsyonların da bu tip operasyonların hızlı bir şekilde ilerlemesine büyük katkı sağladığını belirtmekte fayda var. Küçük kesik kalp cerrahisinde periferik kanülasyon çok önemli. Bunun için femoral arteri, aksiller arteri, bazen özellikle vakalarda karotit arteri ve venöz yolla da jugüler venle femoral veni sıklıkla kullanmaktayız. Tabii burada en önemli tartışmalı konulardan bir tanesi bu kanül seçimini neye göre seçmeliyiz? Ve kullandığımız Seldinger, açık Seldinger tekniğinde eskiden gördüğümüz birçok femoral komplikasyonları, bacakla ilgili komplikasyonları artık görmüyoruz. Ama şunu biliyoruz ki Lamelas'ında yayınlamış olduğu büyük çaplı yayınında da belirttiği üzere vücut kütle, vücut yüzey alanı 1.7'nin altında olan hastalarda 15 French, 1.7 ile 2.1 arasında olanlarda 17 French, 2.1'in üzerinde olanlarda da 19 French arteriyel kanülün yeterli bir akım sağladığı göz önünde bulundurulabilir. Tabii endüstride bu yönde birçok kanül elimizin altında ve bunların birçoğuna ulaşmakla birçok femoral komplikasyonların, periferik kanülasyon komplikasyonlarının önüne geçtiğimizi görmekteyiz. Femoral kanülasyonda ne tür özel noktalar var? Tabii burada en önemli noktalardan birisi preoperatif hastanın periferik arteriyel hastalığın olmadığını tespit etmek. Çünkü biliyoruz ki bu tip durumlarda stroke riski yüksek ve operasyonun başarısı ciddi oranda etkilenmekte. Bu tip durumlarda mutlaka kanülasyon yerini değiştirmek lazım. Eğer gerçekten femoral arter kanülasyon yeri güvenli bir ortam sağlamıyorsa cerrahinin başarısı için kanülasyon yerini değiştirmek çok önemli. Ve bu bakımdan da aksiller arter bizim için önemli bir opsiyon. Aksiller arterin en büyük avantajı femoral artere göre aterosklerozdan daha az etkilenir. Daha ince bir arter olmasına rağmen femoral arterde kullandığımız kanülün bir boy küçüğünü kullanarak yeterli indeksi ve perfüzyonu sağlayabildiğimizi bilmekteyiz. Fakat aksiller kanülasyonla ilgili en önemli kısıtlayıcı etkenlerden bir tanesi eksplorasyon süresi, brachial plexus'ta olan yakın komşuluğundan dolayı cerrahlar tarafından çok tercih edilmek istenmemesi. Tabii bu tip operasyonları, küçük kesilen operasyonları yapabilmek için cerrahi alet ve sarf malzemesi bizim için çok kıymetli. Bu bakımdan şaftlı aletler, nut pusher'lar ve özellikle cross clamp yani çift foot clamp'ler bu bağlamda bize büyük katkı sağlamakta. Aynı zamanda kullandığımız yumuşak doku ekartörleri, endokloozlar ve birçok cerrahi sarf malzemesi bize bu konuda destek olmakta. Ayrıca son yıllarda düğüm bağlama için kullandığımız sağ üst fotoğrafta gördüğünüz kornat aygıtı, aynı zamanda sol üstte gördüğünüz sol atrial ekartör ve teknolojinin katkılarıyla hem 3 boyutlu video sistemi hem de robot küçük kesik kalp cerrahisilerin başarıya ulaşmasında büyük aşamalar kat ettirmiştir diyebiliriz. Cerrahi ekibin deneyimi küçük kesik bypass operasyonlarında diğer önemli bir nokta. Tabii ki bütün operasyonlarda cerrahi ekibin deneyimi çok kıymetli ama küçük kesik kalp cerrahisi tamamen bir takım işi ve sadece cerrahla halledilebilecek bir operasyon tipi değil. Bu bakımdan cerrahi ekibin deneyimi ve bu konudaki eğitimi çok büyük önem arz etmekte. Leipzig'ten yapılan bir çalışmada küçük kesiyle yapılan bypass operasyonlarında 50 vakadan daha az yapan cerrahların komplikasyonlarıyla 100 vakadan daha fazla deneyimi olan cerrahların komplikasyonları arasında neredeyse 3 kat fark olduğunu söylemek mümkün. Aynı şekilde Malcolm Gladwell'in de makalesinde tespit ettiği üzere bir kişinin 10.000 saat bir iş üzerinde mesai harcamasının ustalıkla eşdeğer olduğunu söylemekte. Bu bakımdan deneyim hakikaten çok kıymetli. Size bu slaytta bizim merkezimizde yaptığımız mini sternotomi operasyonuyla aort cerrahisi, asanen aort replasmanını ve aort kapak cerrahisini göstermek istedim. Bu hastaların operasyon sonrası görüntüleri. Bu da sağ torakotomi ile yaptığımız kapak operasyonlarındaki bir planlama şeması. Bu bizim opera ettiğimiz bir hastamızın, mitral kapak hastasının hem operasyon kesi skarı kameranın yerleştirildiği yer, aynı zamanda chitwood clamp'in konulduğu yeri görmektesiniz. Bu da o hastanın operasyonundaki peroperatif ameliyat görüntüleri olarak gösterilebilir. Torakotomide, sol torakotomide en çok başvurduğumuz operasyon tipi koroner bypass, minimal invazif bypass. Bu yöntemle tek damar atan kalpte bypass yapabiliriz, çok damar atan kalpte bypass yapabiliriz ya da cross clamp eşliğinde arasında kalpte çoklu bypass operasyonlarını yapmamız mümkün olabilmekte. Tabii bu hastalar her geçen gün başvuruda daha da sayılarını arttırmakta ve biz cerrahlar ekip olarak da bu tip operasyonları daha fazla sunar hale gelmekteyiz. İntrakardiyak kesi gerektiren, yani kapak operasyonu, ASD, miksoma gibi operasyonları gerektiren küçük kesi ameliyatlarda hava çıkartma çok önemli bir nokta. Bu bakımdan ameliyat sırasında bunu minimal invazif bypass cerrahisinde çok ihtiyacımız yok intrakardiyak işlem yapmadığımız için. Fakat kapak operasyonlarında cerrahi ortama karbondioksit verilmesi, hastanın ameliyat sonunda sola rotasyonuyla hava boşaltma manevralarının yapılması, kalbin doldurulması ve akciğer ventilasyonu, defibrilasyon öncesi transözofajal eko ile sol boşluklarda hava kalmadığının tespiti ve aortik ventin önemli katkı sağladığını söyleyebilirim. Tabii son slide olarak size söyleyebileceğim şey şu, minimal invazif kalp cerrahisi aslında ağrının hastadan ekibe, cerraha ve diğer çalışanlara aktarılması operasyonu olarak belirtilebilir. Beni dinlediğiniz için çok teşekkür ederim. Eğer konuyla ilgili daha ayrıntılı bilgi almak isteyen perfüzyonist dostlarımız, arkadaşlarımız olursa da irtibata geçmekten her zaman keyif duyacağımı iletir. Hepinize verimli, sağlık, huzur dolu bir kongre dönemi diliyorum. Saygılarımla.
Cüneyt hocamıza teşekkür ediyoruz. Salondan sorusu ve katkısı olan varsa alabiliriz. Lütfen hocam.
Değerli hocam, bu güzel sunumunuz için teşekkür ediyorum. Uzun yıllar Cüneyt hocamla birlikte çalıştık. Aslında minimal invazif kalp cerrahisi ağrının hastadan ekibe aktarılması olarak tanımlanıyor. Bu güzel, bilgilendirici, ufuk açıcı sunumu için tekrar kendisine teşekkür ediyorum. Sağ olsun.
Biz de değerli başkanımız Fehmi'ye teşekkür ediyoruz. Cüneyt hocam sunumunuz için teşekkürler. İyi günler diliyoruz.
İyi günler, ben teşekkür ederim.
Our next speaker is Lucrezia Ajro. She is going to present Advancing Boundaries in Cardiopulmonary Innovations.
Hello, good morning, everyone. I'm sorry if I was late. So today I will share with you a new presentation about advancing boundaries in cardiopulmonary innovation, with a particular focus on optimizing CPB using the no, that's not. I'm sorry. I was okay. Using landing implants. So, as perfusion practice continues to evolve, both cardiopulmonary bypass and ECMO are moving toward a model that is increasingly personalized, data-driven. And our patients today are more complex, often presenting with I'm so sorry, it was super, okay. Where is that? So they present a lot of comorbidity, and our surgical procedures are longer and physiologically demanding in this and physiologically demanding. So in this setting, reeling solely on static parameters is no longer enough. We need a real-time monitoring, not only to observe what is happening, but to understand how the patient is responding dynamically through the procedure. The real challenge and the real opportunity is to transform monitoring data into actionable clinical decisions that guide flow, hemoglobin management, gas exchange, and overall patient support. Landing Advance is designed to support both CPB monitoring and ECMO monitoring, of course. One of the key strengths of the system is that it is a fully customizable layout. Parameters, color, and alarm settings can all be tailored to the user's preferences or the specific clinical scenario. This makes its interface intuitive and reduce the cognitive load during critical phases of support. Another important aspect is the plug-in and the plug-and-play philosophy. Sensor and probes can be connected quickly, allowing fast setup and immediate access to diagnostic information, which is essential because every second counts. In our clinical practice, Landing Advance has become a real-time companion during cardiopulmonary bypass. It allows us to move beyond static values, integrating metabolic and hemodynamic data into a single intuitive interface, because it's very easy to interpret, it's very easy to see. During CPB, we monitor oxygen delivery, oxygen consumption, VO2, and extraction ratio. Parameters that provide immediate feedback on the patient's aerobic condition. These enable patient-tailored perfusion, helping us to anticipate imbalance before they translate into a post-operatory complication. Landing Advance also supports data correlation between perfusion and patient's metabolism. For example, linking change in flow or hematocrit to various lactate trend. Its visualization tools help us understand how small adjustment at the pump translate into global physiological effect. In short, it brings clinical meaning to the numbers we already collect, allowing perfusionists to combine their experience with objective and real-time feedback. During cardiopulmonary bypass, perfusion becomes the artificial interface between patients and the physiology of itself. Perfusionist goal is to maintain adequate oxygen delivery and metabolic balance, but patient's condition and surgical phase can change rapidly. Without continuous feedback, many of these changes remain unnoticed until it's too late. Lactate rise, for example, as VO2 drops, or microcirculatory flow deterioration. So, the real-time monitoring allows the perfusionist to detect early deviation in oxygenation, perfusion pressure, and flow distribution. Adjust flow temperature or hematocrit proactively rather than reactively. Preserve tissue oxygenation even in complex or prolonged case. Transform perfusion from a fixed setting into a dynamic patient-centered therapy. And ultimately, continuous monitoring bridge the gap between physiology and technology, supporting safer and more and guiding a more individualized perfusion. All of these are, of course, according with the ASCTS recommendation. Here, a clinical example in my experience. So a patient of 72 years old with a surface body area of 1.95 meters square, undergoing aortic valve replacement with mild left ventricular dysfunction. Perfusion flow was setting at 4 liter and 600 milliliters. And the medium arterial pressure, the medium arterial pressure was around 65 millimeters of mercury. Landing advance monitoring, with the landing advance monitoring, we checked a progressive drop in the O2 below 280. And an O2 increasing from 28 to 38%. And LATAC trending upward 0.9 to 1.6. So what is the interpretation? Because perfusionism is always the focus of interpretation. Despite the stable pump flow and pressure, tissue oxygen delivery was becoming insufficient, suggesting an early oxygen depth. So the perfusionist intervention was increase pump flow from passing from 4 liter and 600 milliliters to 5 liters per minute, optimize hematocrit thanks to cell server infusion, adjusting VO2 and gas flow on the oxygenator, and the result was, at the end, a restored DO2 above 330 milliliters, with an O2 normalized to 29% and lactate stabilized. Metabolic balance recovered before reperfusion with post-operative lactate remained inferior of 2 millimole per liters. So the key message of this short story is that landing advance is enabled to early recognition and correction of inadequate oxygen delivery during CPB, of course, in this case, supporting our perfusion. So, a real important thing is to understand the signification of the extraction fraction. While DO2 depends on pump flow, hemoglobin, and arterial oxygenation, the oxygen extraction ratio reflects how much oxygen the tissue are truly using. An increase in O2 for example, when it passes from 35% to 40%, indicates that the oxygen delivery is becoming insufficient relative to the consumption. It anticipates the metabolic distress before lactate rises or SVO2 drops. I want to highlight another important and crucial point. A system like landing advance is not only valuable during CPB. The real advantage is that it becomes even more important in ECMO, because it's here that the patient's physiology is not static but is dynamic and it changes each minute. So each variable can be really important because physiological variable change every time during ECMO assistance. And our goal is to maintaining the right balance between oxygen delivery, CO2 removal, and patient's metabolism. That is essential. Small variation in flows with gas can be detected, and it is very important because in this case, the clinician is able to track in real time VO2, VO2, and VCO2 and to assess the patient's metabolic condition. Monitor sweep gas flow, pressure gradient, and the CO2 removal efficiency. And we can also detect early sign of membrane dysfunction or oxygenator clotting. And even we can evaluate the interaction between patients and ECMO system, especially during weaning. This recent study by Butts and colleagues focus the attention on improving ECMO therapy through better monitoring of oxygenator performance. The author, in fact, analyzed the clinical and technical parameters that can indicate early oxygenator deterioration, aiming to define key indicators for safe and timely change-out. They emphasize that traditional ECMO parameters such as pump flow, arterial oxygen saturation, or VO2 are not sensitive enough to detect early decline or oxygenator efficiency. Instead, continuous trending of pressure drop across the oxygenator together with the rate of CO2 removal and the overall gas exchange performance. All of these parameters can reveal membrane coating or dysfunction of ECMO membrane. And this can appear before clinical signs of hypoxemia or acidosis appear. This paper suggests that adopting an integrated real-time monitoring system that combine hemodynamic and gas exchange data to guide predictive rather than reactive management, allowing teams to plan oxygenator replacement in advance, avoid emergency changeouts, and improve both safety and cost effectiveness. Another clinical case in a patient of 62 years old, post-cardiotomy in VA ECMO for cardiogenic shock following mitral valve replacement. Initial ECMO secting flow was 4.5 liters per minute, sweep gas 4 liters, and VO2 100%. At start, at the first time, it has a stable lactate and an O2 of around 28%. So there was a change in situation after 6 hours, and with a progressive increase on O2 from 28 to 42%, and DO2-VO2 ratio that dropping below 2 with a rapport to 1, and gradual rise in pressure drop across the oxygenator, decreased VCO2, and flattened also of CO2 removal curve. So clinically, the arterial pressure was stable, with the saturation that was stable at 95%, and no obvious alarm from the console appears. The interpretation was the combination of rising O2 and pressure drop along procedure and along the assistance with a reduced CO2 elimination suggests early membrane dysfunction and clot formation inside the oxygenator. And so we take the action to cross-check gas line pressure, confirm the increased post-membrane resistance, switched so to standby oxygenator and performed the oxygenator change, of course. So today Another dispositive that can be connected to landing advance is the landing breath. Because during ECMO, patient management goes beyond maintaining flow and oxygenation, and it requires understanding how the native lung and the membrane lung share the gas exchange load. So we have a lot of clinical insight provided, quantify CO2 removal from both the native and membrane lung, detect change in native lung contribution, identify membrane dysfunction, and a trend in pressure drop and sweep flow efficiency. There's an important clinical impact because it supports winning strategy, prevent late detection of membrane failure, and optimize ventilation settings. This experimental study evaluated a novel volumetric capnometer device to enable continuous monitoring of CO2 removal by the membrane lung during ECMO support. Research conducted work in an animal porcine, VA ECMO, model with varying blood flow sweep gas ratio. The capnometers measure VCO2 and membrane dead space. And these parameters, the VD that appears, the VD SML, demonstrated an high accuracy and strong correlation with the standard measurement technique across multiple flow conditions. The results suggest that continuous real-time measurement of CO2 removal is feasible and reliable, and the authors conclude that further clinical studies are needed, but the data support the concept of continuous membrane lung performance monitoring in ECMO. So, here I list some clinical advantage and some technical advantage of using landing bank advance in our perfusion practice every day in CPB or in ECMO. Some take-home message from parameters to physiology is one of the most important things about landing advance because it brings continuous insight into oxygen delivery, consumption, and extraction. It is able to an early detection to improve patients' safety and also the practice of perfusionists. And the most important is the clinical impact because it supports tailored perfusion and winning strategies, optimizes oxygenator management, and strengthens physiologic decision making in real time. Thank you for your attention.
Thank you for your presentation. Is there anyone? Any questions? Thank you. Thank you. No questions.
Thank you.
Dear ladies and gentlemen, colleagues, first of all, my sincerely greetings to Antalya. It would be so fantastic to be there, but unfortunately, I have a lot of sick leaves in my department, and for that reason, unfortunately, I can't come. Sorry for that. And yeah, however, I want to start with my presentation. My name is Adrian Bauer. I'm a perfusionist since 30 years, almost doing minimal invasive systems since 20 years now, a little bit more than 20 years, and have, of course, a lot of experiences with MIAC systems, and want to introduce you about the differences a little bit, or the justification of minimal invasive approach of a cardiopulmonary bypass towards to a more hybrid approach, optimized, so-called optimized perfusion. what's the problem? Do we have a problem? Is there a battle between optimized and minimized system? No, in my eyes, it is not. And I will guide you through that presentation and hopefully could be able to show you that there is no difference. There is only one way, and the way must be towards to a better patient treatment. What's the problem with a cardiopulmonary bypass? You all know that. It's a very complicated system. We have artificial surfaces there. We have an open venous reservoir there. We have a pump there. We have shear stress and so on. You all know that. You're all experts. And what we are doing with a cardiopulmonary bypass is to bringing together an artificial system like the cardiopulmonary bypass with a biological system, the human body. And then some reactions are going on. And we have to consider how can we improve that? Is there a possibility to get a higher biocompatibility? And that's exactly what we want to have. And we have all that reactions of the body, and we try with a minimal invasive approach to lower that reaction, to lower that triggers to the body. And we have a couple of things what we can do. We can look at the surface. We could have a surface treatment. We could look at the venous reservoir. We could reduce or even avoid the contact between blood and air. We can look at the oxygenator to improve then the arterial pump. And last but not least, the cardiotomy suction. We lose a lot of blood during the procedure. And I heard that text a couple of days ago discussing a new paper. And the surgeon said, surgeons love shed blood. Sucking, so laughed at sucking, but at the end, I can tell you, shed blood is not even a good blood. Shed blood is often bad blood. So if we look to the literature, then we found also old papers 20 years ago, or here from Ferrari from 2011, that there are some space for improvement, looking at hemodilution, surface coating, shed blood separation. I talked already about a 1B recommendation to avoid shed blood, using of a cell saver. We could use a centrifugal pump instead of a roller pump, and so on. That's also here a recommend 5 years later by Ferrari. So there are some recommendations already going forward to reduce the side effects of a cardiopulmonary bypass. And if you look then to the current publication of our guideline, and even to those one from 2019, then we find strict recommendations on arterial pump. The use of arterial pump should be considered as a centrifugal pump even for longer CPP times, and that's still the same recommendation in 2024. Should be also considered to improve hemocompatibility and therefore minimize the invasivity of the pump within the system. We can also look to the venous reservoir and find a lot of recommendations there to limit the trauma of the blood elements, to use the separate of cardiotomy suction, to use of a closed venous reservoir. We have a recommendation of 2B. And if you look then to mediastinal shed blood, it should be considered to discard it. I never would do that. I think the better way is to use of a cell saver to have the possibility to get the red cells back at least. So, but there is a minimizing of that effect as well recommended. So we should reduce or should minimize the priming. Yes, of course, we have to minimize priming, and because then we have a lower hemodilution, then we have a better DO2, a better transfer of oxygenation to the body. So minimizing of priming is also a very important thing, but believe me, not the important thing at all. So this is one thing what we can do. We can look to the surface. At the surface, there are a lot of reactions. There's also shear stress, of course, but there's also a reaction of the body to that, or of the blood to that artificial surface. And that's also high recommended, always with a 2A in regard to reduce complications and in regard to protect the lung of inflammatory response and to limit oxidative stress with a 2A. That's our current guidelines and a very important thing. So, and what we try to do is with a minimal invasive approach to combine all that things in one concept, and that's the minimal invasive approach. That's clearly described by the Meactus Society. They're giving out a clear describing of the different systems and what should a minimal invasive approach should contain. And you can read that all in that paper, and I already show you the most of that. So anticoagulation could be also reduced because of that minimal approach, because if you have a closed system, if the surface is treated, and it is, then it's like an ECMO. Then you are able to reduce your target ACT down to 300 seconds. This was one of my projects during my PhD study, and we found out that we can reduce. We have no higher endocrine thrombin potential during the procedure, which is a good thing because we don't want to have any coagulation during the process. And afterwards, the ability of the blood to coagulate is better. So that could be the next thing what you can do if you use a closed system with a surface treatment. So then at the end, there is an update paper of the Meactus Society from 2021, and you find a lot of recommendations there, and they found out that you are able to reduce transfusion, atrial fibrillation, what could be the reason in the reduced inflammatory response of the body. You can have a better renal function, all that with a 1A, with a 2 recommendation, and I go a little bit to the side, then you find that for myocardial protection, neurological protection, and organ protection, and 2A for inflammatory response, and the mortality is also reduced, and it's a 2B. There was a big study regarding to the endpoint mortality. The COMEX trial, and also this trial is published, but not with the whole patient group. The results are good, but because of several reasons. One reason was the pandemic situation when this study runs. The study was stopped with more than 1,000 patients. However, the results can be read and are good. So they also we have also recommendation from in our new guidelines from Weber, D. Sommer, and Professor Kunz, and it's published by the EBCP as well. It's recommend to optimize the CPP system, and we have a 1A for that, and that includes the MEAC approach. And all what I talked before are that things what we have to consider. So MEAC should be also considered over standard conventional bypass in order to reduce the incidence of new onset of atrial fibrillation. There we have a 2A for that recommendation there. So the latest research are also very interesting. We have good studies out. This is one of the studies. It's a meta-analysis from 2021, including a lot of studies in it. And what they found out is that MEAC demonstrate, they called it MEAC. You know, the definition is MEAC, but however, MEAC demonstrate clear post-operative benefits over conventional bypass systems. Also very interesting study and a meta-analysis on that. Yeah, the COMEX trial, I already mentioned that, stopped after 1,071 paid participants, but what they could show is a lower risk of having less than 1 perfect health index score in the MEAC group compared to the conventional group. which is also a very interesting thing. I think we should more look to health-related quality of life, not only to bleeding amounts and all that stuff. So interesting approach. The conclusion is that MIAC reduced the relative risk of primary outcome events by about 25%, which is a nice outcome, I think. And the risk of serious adverse events was similarly reduced in both groups. So there's also a recommendation from this study in using a MIAC approach. So, what they also found is that the community was very active also to optimize that so-called conventional system. And I can imagine that probably conventional, someone provokes to go forward. I'm not conventional. I can do also something. Perfect. Thank you for that. To optimize a perfusion system is always the right approach. And if the people optimize their own system because of the pressure coming out of the MIAC study, do it. And that was exactly what's happened in that study. That means that conventional systems were better and better. And that's exactly what we want to see, that we improve our approach going forward with improving patient care with systems. That's our brand new hybrid approach. We have now a system with the ability to have a closed system. And when we change the clamp here from one to the another part of the system, then we have an open system. And that's exactly what I think what we can do to going forward with the so-called optimized system or hybrid system, to have one system with both abilities. That's a surface-treated system. There's a centrifugal pump, and there's the possibility to have a shed blood separation or not. And then you can decide during the procedure whether you use it as open system or a closed system. So perfusion must be patient-tailored. That's very important. The patient is in the middle. It's overall. And if we are doing mini systems, and if we're using mini systems, we have also to improve our performance of perfusion. And all the new heart lung machines, that could be the one from Livanova and also from Spectrum to Quantum, they all have fantastic data science systems on it. And we have to use that system to improve our perfusion. I can tell you, a bad performed MIAC is below a good performed optimized or conventional bypass systems. We not only need treated systems and centrifugal pumps, we also have to use it in the right way. And that would be my message. Use your systems in the best way that you can, collect data, learn from the data, and probably AI will help us in the future to improve perfusion. And that's the direction that we should go. And at the end, tailored perfusion is tailored patient care, and do it together. We have to optimize what we do, and then we will have a good part within the cardiac team, but also in the medical teams somewhere. Thank you very much for your attention.
Adrian bağlı mı şey? Adrian toplantıya bağlı mı şu anda? Konuşabiliyor muyuz?
Yeah. Can you hear me?
Yeah, we are hearing you. Good morning.
Yeah, very good, very good.
Thank you very much for your nice speech.
Yeah, thank you. It's a pleasure for me to be there. And Günaydın, Günaydın. I'm so sorry not to be in your wonderful country in town, but I'm happy to be part of this conference. And yeah, I'm open for any question regarding the talk, of course.
Salondan soru veya katkı var mı arkadaşlar?
There was a little bit of mistake within my speech when I hear the speech now. We don't have two to 1A recommendation for using of MEAG optimized systems in our current guideline from the EBCP. It's a 1B. So there, probably some of you saw that, but we are on a good way with recommending to optimize systems and to use of MEAG systems, but we need more studies, and that could be one thing what I could or what I want to deliver to the room, make studies. If you are consider or you already use MEAG systems, please do studies on it, and even much more important, publish them. Then we could be able in the future to have a better evidence for using of better perfusion systems.
Adrian, what's the proportion of the MEAG use compared to conventional CPB proportion?
Yeah. The proportion in our house is in our clinic that we are using MEAG systems for almost all the catheter patients, which means that if we have a patient with a calcified aorta, for example, or one vessel disease, we are doing it in the off-pump approach. But all the other cases will be done with a MEAG system. And with the new hybrid system, we are catching more and more procedures also from aortic valve replacement or mitral valve replacement. And the goal is, the target is to use the hybrid system for all the procedures. For example, this night I have had a patient, he get an UFO procedure. That means both valves was replaced, means the aortic and the mitral valve. And this guy was a typical German guy with 130 kilograms, and he has a height of 190 centimeters. And for this guy, I decided not to use the hybrid approach, because we have a free inch line at the venous side, and that could be a potential problem for that patient. So there are some restrictions, but in principle, this is possible for all the patients, in principle. So we have to improve more and more, but we are on the way to get more and more patients into the program.
Adrian, thank you for your nice speech again, and best wishes from Antalya. Now we are closing the session.
Okay.
See you another time. See you another time.
See you later, and enjoy the break.
Thank you.